Pollen and hyperglycemia. That will be our topic of discussion today. Last time we did discuss functions of diabetes mellitus. So hyperglycemia. Hyperglycemia can occurs due to a variety. It includes one by decreased insulin secretion, by increased glucagon secretion, increased hepatic glucose production, neurotransmitter dysfunction when there is like a decreased glucose uptake, that is when a decreased peripheral uptake occurs. When kidney increase of glucose reabsorption, increase lipolysis, and decrease incretin effect. Walks in with the history or a person walks in with newly detected hyperglycemia, can you directly give him OHA? The answer would be a simple no. You have to consider something. It's to consider when you start a patient with OHA. The efficacy of the drug, the safety of the drug, the side effect, the effect on their weight, risk of hypoglycemia, effect existing comorbidity, the cost of the medicine, the patient's preference, and long-term cardiovascular outcome. Is that use, and it will be discussed under these five topics. Big one heads, the most common will be metformin, sulfonyl urease, thiazolidines, glinides, alpha-glucosidase inhibitors, DPP-4 inhibitors, SGLT2 inhibitors, oral GLP-1 analogs. What does metformin do? Metformin had a wide variety of actions. It includes the action in the intestine, that is, increased anaerobic glucose metabolism and increased glucose turnover. There's a term written here known as lactate, and that we'll be discussing in a while. And in liver, it decreases the gluconeogenesis and glycogenolysis. That is, it decreases the hepatic glucose production. In the muscle, it increases the glucose uptake on oxidation and increased glycogenesis. And eventually, all these can lead to decreased hyperglycemia. So when should we take a tablet of metformin? Since it decreases the hepatic glucose production, a standard tablet should be taken along with the meals or immediately before the meals. We'll start with a dose of 500 milligram or 850 milligram that we all know. Dose can be increased slowly to attain a blood glucose level control. And we have certain formations like extended release and sustained release, etc. The maximum dose now they're recommending is 2500 milligram per day or 3000 according to some sources. What we can predict in a patient when we give them metformin decreases the fasting plasma glucose level 50 to 90 milligram per deciliter and decreases the HbA1c by approximately 1 to 2%. It can cause GI intolerance, vitamin B12 deficiency, and lactic acidosis. Why? Because it can cause anaerobic glucose. And conditions you should be in caution with in renal failure, in cardiac failure, liver failure, and overdraft because it can produce minor amounts of lactate. Sulfonylureas are drugs that can release the insulin, and the common drugs that we have will be glibenclamide, glimepiride, glycoside, and glipizide. Sulfonylureas acts is somewhat similar to the normal release of insulin. In the previous video, I had told the release of insulin, how it happens. Glucose is taken up by the GLP-1 or GLP-2 in it undergoes glucolysis and pyruvate is formed and it releases ATP. ATP after it gets released inhibits the ATP's potassium channels and eventually calcium influx occurs and CAMP increases and insulin is released. See, In the ATPase potassium channel, you can see the sulfonylurease receptors and inwardly rectifying potassium channels. And this is a point where sulfonylurease is normally released. These are the drugs that we commonly use. We have glibenclamide, glimepiride, glycoside, glyc- glycoside XR, glipizide, and dosage is written here. Most common side effect, most common benefit these drugs have. Glibenclamide, if you can see, they have a very high risk of hypoglycemia. So you need to avoid them in elderly and if renal failure. And glimepiride, since all these drugs can cause weight gain, and among that, glimepiride causes less weight gain, and it has a cardiac favorable outcome. And glycoside also supplements lowers weight gain, and it has an additional favorable influence on platelet aggregation and fibrinolysis. Glycoside also single day dosing because it is extended release, and glipizide short duration multiple dosing, better control on postprandial sugars. The sulfonylureas drugs are said to reduce your blood sugars by 40 to 70 milligram deciliter and HbA1c by 1 to 2%. What are side effects? Just as I said, it can cause weight gain, hypoglycemia, and adverse cardiovascular effect. The controversy is about this cardiovascular effect, how it produces cardiovascular effect. See, a patient, when he gets an coronary occlusion, the potassium efflux through the KATP channel shortens the AP duration. So, and there will be decreased calcium influx. We all know that, and decreased intracellular calcium. And this causes decreased delay after depolarization. Depolarization can occur early, but there can be reentrant arrhythmias and when sulfonylurea. So we all know that somehow it blocks your potassium channels, and this causes it prevents the shortening of AP duration. Calcium influx occurs, and there will be increased delay after depolarization. And so it can decrease the ventricular fibrillation, but this is worse. Next group of drug is the non-sulfonylureas, which include hyperglycinide and natiglinide, shorter acting spinal insulin release, quicker attachment and earlier detachment, and no need to take, and so need to be taken along with meals. The non-sulfonylurea secretagogues act on the non-SU receptor on beta cell and enhance insulin secretion, and after that, the mechanism is same as that of sulfonylureas. It's said that these drugs can be taken in elderly with whom hypoglycemia is a concern. Patient with kidney failure or liver failure, acticlinide is a choice, and patient with irregular meat patterns, fast like people who are fasting, policemen, politicians, etc., and people with uncontrolled postprandial sugars. Side effect causes will be hypoglycemia. It can eventually lead to hypoglycemia. We have the thiazolidine ions, which are PPAR gamma agonist. So after the insulin gets released, the action of insulin on each part of the body will be based on our gene distribution, the gene effects, and also protein translations. And among them, one receptor is a PPAR gamma receptor, and promotion of this PPAR gamma can increase our glucose uptake and utilization, and also lipogenesis and adipocyte differentiation. It's like pioglitazone, rosiglitazone, trogaglitazone are the drugs that are included in this category, and it reduces the insulin resistance by binding with PPL gamma receptor, that is peroxisome activated receptor. It also reduces hepatic fat accumulation and promote fatty acid change. Side effects include peripheral edema, CHF, weight gain, fractures, macular edema, etc. And the drug we are usually avoids in cardiovascular risk will be rosiglitazone. We also avoid pioglitazone in cardiovascular diseases.